Okay, next we have the cortisol. Okay, cortisol. So cortisol is the principal glucocorticoid and its function is for gluconeogenesis. So it has actually an anti-insulin effect. So when we say gluconeogenesis, our glycogen or other sources of glucose, okay, will be converted to glucose, no? So that there will be presence of glucose in the circulation. So because we have what we call our non-carbohydrate source of glucose. So when we say gluconeogenesis, glucose is glucose is converted from non-carbohydrate sources. Okay? So glucocorticoid can also be an anti-inflammatory and immunosuppressive. So your cortisol is still regulated by your adrenocorticotropic hormone and it is bound and transported by transcortin. So it has a diurnal it is a diurnal hormone because high levels are in 6 to 8 a.m., low levels are in 10 to p.m. to 12 midnight. So our specimen would be serum and 24-hour urine to check for adrenal hyperfunctions. Reference value will be 5 to 25 micrograms per dl or 140 to 619 nanomole per liter. And the best time to collect for cortisol is 8 to 10 a.m. So we have what we call our urinary metabolites. We have the 17-hydroxycorticosteroid, which is measured by Porter-Silber method, and our reagent is phenylhydrazine in H2SO4 plus alcohol, and the resulting color is yellow. We also have the 17 ketogenic steroids, which is measured by Zimmermann reaction, and our reagent is metadinitrobenzene, and the resulting color is reddish purple. Okay, so sa F zone natin nakikita ang production ng cortisol. The main steroid is cortisol. Main regulator is our main regulator is our ACTH and the main function is for blood pressure and glucose homeostasis. Okay? So we have here the syndrome and the symptoms. So adrenal insufficiency, okay, there will be hypotension, hypoglycemia, weight loss, and weakness. For cortisolism, you have hypertension, hyperglycemia, sexual obesity, and weakness. So let's talk about the hypercortisolism and hypocortisolism. Okay. So that is referring to our Cushing's syndrome. It is a group of clinical and metabolic disorders characterized by adrenocortical hyperfunction. So there is excessive production of cortisol and ACTH, but there is decreased aldosterone and renin. So remember that it is in the F zone and G zone ang responsible for the aldosterone. So it is caused by overuse of steroids. So Cushing's disease, it is an ACTH secreting pituitary adenoma. So Cushing's disease is caused by a pituitary adenoma that results in the overproduction of ACTH. So autonomous cortisol production from an adrenal tumor, ectopic ACTH or CRH production. So these are the clinical manifestations or the physical manifestation of Cushing syndrome. So we have a moon face, dark facial hair in women, okay, buffalo hump, osteoporosis, cardiac hypertrophy, obesity, abdominal striae, and amenorrhea in women, skin ulcer or poor wound healing, and muscle wasting. So screening tests are the following: 24-hour urinary free cortisol test, overnight dexamethasone suppression test, midnight salivary cortisol test, and for the confirmatory test, we have the low-dose dexamethasone suppression test, midnight plasma cortisol, and the corticotropin releasing hormone stimulation test. So for the patient preparation, okay, for midnight saliva cortisol test, avoid smoking on the day of specimen collection. For midnight plasma cortisol, patient should be admitted for at least 48 hours. Insertion for IV access before 10 p.m. and patient should be sleeping at the time of blood collection. So for the overnight rapid dexamethasone suppression test, 1 milligram of the dexamethasone is orally taken between 11 p.m. to 12 midnight. Blood is collected the following day, 8 to 9 a.m. and urine may be tested for 17-OHCS. So the normal is cortisol less than 5 and 17-OHCS should be less than 4 milligrams. For the positive result, Okay, cortisol is not suppressed, that is more than 5. And for the 17 OHCS, that is more than 4 milligrams. Okay, sa low-dose methoxazole suppression test, 0.5 milligram oral dexamethasone is given over 6 hours for 2 days. Cortisol is measured 15 minutes after oral dose, and 24-hour urine and serum samples are also collected as specimen. So the positive result would be elevated serum cortisol level. For the endogenous Cushing syndrome, you have the ACTH-independent hypercortisolism. So serum cortisol would be more than 15 micrograms per DL, and serum ACTH would be less than 5 picogram per microliter. Okay, between 5 and 15 picogram per microliter. So ACTH-dependent hypercortisolism, the serum ACTH should be more than 15 picogram per microliter. So our method would be two-site IRME or immunoradiometric assay. So we have what we call your primary cortisolism. So it is what we call our Addison's disease or the adrenal insufficiency. So this is due to the destruction of the adrenal cortex caused by autoimmune adrenalitis. So this will lead to hypotension, hyponatremia, hyperkalemia, hypoglycemia, weight loss, and hyperpigmentation. So for the screening test, we have the ACTH stimulation test. And for the confirmatory test, we have the insulin tolerance test. Okay, so we also have the secondary and tertiary hypocortisolism. This is due to hypothalamic pituitary insufficiency with loss of ACTH. There is no problem with mineralocorticoid secretion, so there will be absence of hyperpigmentation. Screening test will be ACTH stimulation test, and the confirmatory test is still your insulin tolerance test. So for the ACTH stimulation test, secondary hypocorticolism, it has decreased or no ACTH response. For the tertiary, it has increased ACTH response. So the dose would be 250 microgram of corcintropine IV or IM or intravenous or intramuscular. Blood collection is any time of the day. Normal response cortisol is more than 18 to 20 grams per DL or 500 to 550 nanomole per liter. So serum ACTH, for the primary adrenal insufficiency, that would be more than 50 to 100 picogram. Okay, so ayun na nga, no, we really have a problem with our internet connection. Biglang nawawala. I'm sorry for that. Let us proceed with our discussion. Okay, anyway, so we have it here already. Insulin tolerance test. So that will be the gold standard for secondary and tertiary hypocorticolism. Our oral dose is 0.05 unit per kilogram of kilogram insulin. So blood collection, okay, we have the baseline and then 15, 30, 45, 60, 90, and 120 minutes following infusion. No? So measurement, serum cortisol and glucose. So normal response, increased plasma cortisol, more than 18 microgram per liter or 20 microgram per liter at any time during the test. So overnight metirapone test, it measures the ability of the pituitary gland to respond to declining levels of circulating cortisol, thereby secreting ACTH. So oral dose would be 30 milligram of metirapone is given at midnight. Blood collection collected the following morning at 8 a.m. So normal response would be elevated plasma 11 deoxycortisol. Okay, so positive would be serum 11 deoxycortisol is less than 7 microgram per deciliter and cortisol is less than 5 microgram per deciliter. So we also have what we call our congenital hyperplasia. It is a deficiency of enzymes necessary for the synthesis of cortisol, aldosterone, and sex steroid production. So this will result to decreased plasma cortisol and increased ACTH and androgen levels. So we have here your serum total testosterone and DHEAS. So, all right. So actually, okay, give me a moment. So DHEAS stands for dehydroepiandrosterone sulfate, no? So this is actually a male sex hormone that is found in both men and women. Okay, right. So actually, your DHEAS plays an important role in making the male sex hormone testosterone and the female sex hormone estrogen. So it is also involved in the development of male sexual characteristics at puberty. No, so your DAS is mostly made in the adrenal glands. Okay, so they also help in controlling heart rate, blood pressure, and other body functions. Okay, so small amounts of your DHEAS are made in man's testicles and in women's ovaries. So if the DHEAS levels are not normal, it will mean that there will be problems in your adrenal gland or sex organs. Okay, so that's why it is mentioned there that serum total testosterone in your DHEAS helps in the diagnosis of hirsutism and virilization. Okay. All right. So again, no, we have this hirsutism and virilization. So hirsutism, that is when we are able to uh, observe, we are able to observe for masculine features now in women, especially in hair, So I don't know if you have seen women who have prominent mustache, no, or their hair growth are quite very extensive. And our virilization is just it is a more advanced form of hirsutism. Okay. So virilization is much more progressive. And again, it is a serious form of hyperandrogenism. No, so um women will if we they have virilization, no, women might experience a pattern baldness, no, clitoromegaly, no muscle development, and deepening of voice. Okay, so hirsutism may be due to hyperandrogenism from ovarian, adrenal, or due to some intake of drugs. Okay, so definitive test, we have the 17-OHP measurement in amniotic fluid and genotyping cells from chorionic callus sampling. Okay, so again, your congenital adrenal hyperplasia may result to hirsutism and virilization. So yun nga yung na-mention ko kanina na it can lead to what we call clitoromegaly, meaning the clitoris might enlarge, no? So congenital adrenal hyperplasia. So we have here the enzyme deficiency, the lab finding, and the defective gene. So enzyme deficient, 21 hydroxylase. Lab findings would be 17A hydroxyprogesterone, pregnanetriol, and 17Ks. The defective gene is CYP21. For 11B hydroxylase, you have the deoxycortisol 17, 17-OHCS, and 17Ks. Defective gene is CYP11B1. And we have the 3 beta hydroxysteroid dehydrogenase isomerase. And the lab finding would be 17 hydroxypregnanolone, and the HEA 17Ks. And for the defective gene, we have the HSD3B2. For the 17 hydroxylase, you have the deoxycortisol, and the defective gene is CYP17. So we also have these what we call weak androgens. They serve as precursors for the production of more potent androgens and estrogens in tissues, and they are produced as byproduct of cortisol synthesis. Their transporter is steroid hormone binding globulin, and their precursors are pregnenolone and your 17-OH pregnenolone. Examples are dehydroepiandrosterone or DHEA and your androsterone androstenedione. So excessive levels of androgen results to virilization or pseudohermaphroditism. Okay? So this is actually found in the R zone. Okay? So the main steroid is the DHEA and DHEAS. And the main regulator is not known yet. So syndrome, okay, androgen excess, and symptoms would be virilization in women and children, and gonadal dysfunction, and infertility in men and women. Okay, so now let us talk about the adrenal medulla. It is composed of primarily of chromaffin cells that produce catecholamines. So the precursor of your catecholamines is your L-tyrosine. So we have the epinephrine, adrenaline, norepinephrine, or the noradrenaline, and the dopamine. Okay. So metabolic enzymes, you have the catechol O methyltransferase and the monoamine oxidase. Okay, so the ratio of your norepinephrine to epinephrine in serum is 9:1. Okay, so for the development, we have the sympathogonia. Okay, so what happens here is that we have the sympathetic cells, and then we have the sympathoblast and the pheochromoblast. Okay, under sympathoblast, we have the neuroblastomas and the ganglioneuromas. And for pheochromoblast, we have the pheochromocytomas. So here is the biosynthesis and storage of catecholamines. Okay, so we have there, no? We have the VMAT. VMAT stands for vesicular monoamine transporter. And then we have the NE. Okay, NE stands for norepinephrine, EPI for epinephrine, PNMT for phenyl, ethanolamine, and okay, we have the N-methyl transferase. So in the cytosol, nor in the cytoplasm, NE or norepinephrine is converted into epinephrine by a cortisol-dependent enzyme which we call our PNMT. Okay, so here, right? So any form of stress that increases cortisol levels stimulates epinephrine production. Okay, so here, epinephrine production. So in the adrenal medulla, epinephrine and norepinephrine are stored in the neurocirculatory vesicles, but are in dynamic equilibrium with the surrounding cytoplasm. So they diffuse into the cytoplasm and actively re-enter the vesicles via vesicular monoamine transporters, or what we see, our VMAT. Okay, so they enter the circulation via exocytosis of the vesicle. So they will be released, no, from the vesicle. And the cytoplasmic catecholamines may also be metabolized by enzyme, catecholamine O methyltransferase, or your COMT. Okay, into metanephrines and normethanephrines, which enter the circulation via diffusion. So epinephrine is the main catecholamine secreted by a normal adrenal medulla, which contains 80% of your epinephrine. So the ratio of your norepinephrine to epinephrine in the serum is normally 9:1, which I have mentioned. So in adrenal insufficiency, meaning there is low cortisol, that ratio increases to 45:1 in females and 24:1 in males. So in sympathetic neurons, cytoplasmic dopamine is sequestered into vesicles. They will be converted to norepinephrine and stored until nerve stimulation causes its release into a synapse by exocytosis. Okay. So what you see here is the catecholamine degradation. Okay. So the degradation, okay, all catecholamines are rapidly eliminated from target cells and circulation by three mechanisms. It's either there is reuptake into circulatory vesicles, uptake in non-neuronal cells, and of course degradation. So degradation relies on two enzymes, your COMT and your MAO, okay, that is found within the neurons to produce metabolites, metanephrine, and vanillyl mandelic acid, or your VMA. So here, now there This is your VMA. Okay, so this VMA is coming from your free catecholamines. So metabolites and free catecholamines are eliminated by direct filtration into the urine and excreted as free norepinephrine, which is 5%, conjugated norepinephrine 8%, and metanephrine 20%, and VMA as 30%. Okay, so free catecholamines, no, your epinephrine or your norepinephrine are either sequestered to VMAT-containing vesicle or converted into metabolites. So DOMA, no, our metabolites here are DOMA, no, by uh, neuronal MAOs, and metanephrines by non-neuronal COMTS. So these metabolites are ultimately degraded to VMA. Okay, DOMA by CMTS and metanephrines by MAOs and excreted. So epinephrine, okay, so yeah, so it's either epinephrine or norepinephrine, both of which are in the VMAT. Okay, so just take note of the degradation process. So again, no, they can these metabolites are ultimately degraded to VMA. So all of them will actually become VMA in the process. So again, VMA stands for vanillyl mandelic acid. So let's talk about your norepinephrine. Norepinephrine is a primary amine. Okay, it is produced by the sympathetic ganglia, and the highest concentration is found in the brain, and it acts as a neurotransmitter in both CNS and your SNS. Okay, so the major metabolites would be 3-methoxy-4-hydroxyphenyl glycol and your vanillyl mandelic acid, or your VMA. So epinephrine is the fight or flight hormone. It is a secondary amine, and it is also otherwise known as your adrenaline. It is the most abundant medullary hormone produced from norepinephrine, and they promote glycogenolysis, and they're stimulated by stress, injuries, and anxiety. So for the collection, we collect it via indwelling catheter, and the major metabolite is your vanillyl mandelic acid, or VMA still. Okay, so minor metabolite would be metanephrines, normetanephrines, and homovanillic acid. And for the dopamine, no, it is produced from the carboxylation of 3,4-dihydroxyphenylalanine. It is present in highest concentration in the regions of the brain, and is the major intact catecholamines present in urine. And the major metabolite is homovanillic acid. Okay, so let's talk about the clinical disorders. Okay, first we have the pheochromocytoma. It is the overproduction of the catecholamines due to tumor of the adrenal medulla or sympathetic ganglia. Okay, it is seen in third or to fifth decades of life. And the classic spells, no, or manifestation would be sweating, tightness of chest, headache, tachycardia, and hypertension. So here we also have an illustration of a healthy adrenal gland and an adrenal gland with pheochromocytoma. So here we can see, no, in pheochromocytoma, there is too much adrenaline released from your adrenal gland. So the screening tests of pheochromocytoma is plasma metanephrines and normetanephrines. Method is HPLC, and the diagnostic test is 24-hour urinary excretion of metanephrine and normetanephrine. Pharmacological test, we have the clonidine test. It will differentiate for pheochromocytoma, which is not suppressed, to neurogenic hypertension. So glucagon stimulation test, it is used if it is highly suggestive of pheochromocytoma. So next, we have the neuroblastoma. It is a fetal malignant condition in children resulting to excessive production of norepinephrine. So N for norepinephrine. So high urinary excretion of your HbA or VMA or both, and also your dopamine. So measurement will be HPLC and RIA, and the symptoms are the following. Okay, lump in the abdomen, lump in the chest, bone pain, and bruising around the eyes. So those are the very important things that you have to learn about the adrenal gland, both the cortex and the medulla.